Oh, they just duplicate. Okay. So Kim, you can, here, David, you get this to point, and then Kim, you get this to me.
Not a second.
Sure.
Okay, so this case presented by Dr. Swan, of course. So the history before, I guess she saw you is a little bit lengthy. So 45-year-old female, she went to an eye doctor to talk about getting glasses, thought her vision was slightly below normal. She does not necessarily get regular eye exams, had trouble, especially with nighttime vision. She was thought to maybe have a problem with the optic nerve. She saw another retina specialist who said that the finding was not optic disc drusen. She got a lot of blood work, line, cat scratch, sarcoidosis. She had a brain MRI, which was normal, and had memory testing with a neurologist, which was normal. The LP showed normal pressure, and the test thus far indicated MS. She went back to see Dr. Cohen, and between all of that, she noticed that she does not have trouble seeing. The images in the left eye are a little bit dark or light.
I'm a really fast typer. As they talk, I just type. I can keep up now. I can keep up with people. So they all said, I hire you as a secretary.
So she has an interesting thing of consciousness. She has some visual field loss. She had an MRI for orbits, which may have been normal, but there was some artifact. Okay. So classical history, either hypo or hyperthyroidism. Her vision is excellent. It's 20/16 at distance, J1 at near, and her pressure is normal. So hopefully that gave you a good background.
So you should give us a differential now.
So
exactly.
So she may have optic nerve head edema, and everything else is normal.
Essentially.
Okay.
Or maybe a weird MRI orbits with some maybe artifact. We'll see. Okay.
So this is a fundus photo of the right eye. The media is clear. The nerve looks pretty good. Maybe some obscuration of the border inferiorly. The vessels are not really obscured though. The rest of the retina looks fine. The vessels normal caliber. So maybe a little bit of inferior edema of that nerve. I don't really see any deposits, so I wouldn't think drusen. Okay. So this is a fundus photo of the left eye. Attention is immediately drawn to the nerve, which looks obscured by a dark lesion. Maybe some tortuosity of the retinal vessels. I don't know if I would necessarily call that a swollen nerve.
Yeah, that's fair. So hypopigmented lesion or hyperpigmented lesion overlying the nerve, possible extension into the retina from this photo, unclear if it extends into the choroid. And then the vessels are kind of long. It looks like almost like a vasculitis in the picture initially, but full.
It's infrared right eye, nothing remarkable. Left eye, and again showing this lesion at the nerve that is hypo-reflective.
Good.
So we got a nerve OCT.
I don't know if you can see the numbers, but it's about 100 in the physical article.
So normal.
It's pretty good. It's in the green pretty much. It's a little
Not like
bumpy.
significantly elevated on that left side.
Okay, so OCT of the right eye looks normal. OCT of the left eye but it does look a little bit raised at the nerve now. Why did we not see that before on the nerve OCT?
Oh, because the nerve OCT just isolates the nerve fiber, and also it isolates the nerve fiber at distance from the nerve. So it probably was cutting it a little bit off where the thing is. Or the lesion is.
So I guess we're looking at an OCT cross section of that lesion.
And that's an EDI. So if you're going to look at a nerve, get an EDI and get just the line. The raster scans, which seem like they'd be helpful, actually don't give you the detail because it's just like 1, 1, 1, 1, 1. These scans will do 100 and optimize the image. So if you want to really look at a nerve, which is still unclear, there's no good book on optic nerve EDI scans yet, but it's just kind of interesting.
So on the cross section, the architecture, I'm not sure if it's disrupted or this is just because we're at the nerve, but it's certainly raised. There's some hyporeflectivity beneath the raised retina.
Yeah, it looks like you almost have intact retina. It doesn't look like there's really edema. Because if you have edema, you'll get some like cysts at the edge. Fluid. You know, so fluid. So you really don't see fluid. It just looks like there's something there. It looks like the retina overlying it's pretty intact. I mean, you can see her visions. I mean, she's totally asymptomatic.
Yeah, so nodular elevation. It has that hyporeflectivity you were talking about, posterior shadowing. Is the term that I kept popping up when I was looking at it. Posterior shadowing. And then there are some very tiny like hyperreflective spots in the interretinal and kind of RNFL layers. So this is just a different section. So summary findings. So the pigmented lesion overlying the nerve and adjacent retina. On the IR, there was that hyperreflective lesion overlying the nerve, no real hyperreflectivity. And then the OCT macula had that nodular elevation.
No FA?
There was no FA.
No.
No
I
FA?
don't get a lot of FAs. I don't know what it would have done. I could say it would have shown. I guess I could have looked for leakage. Yeah, I didn't get an FA.
And then that activity. So differential.
So what's the findings? What's it look like?
It looks like freckle at the nerve.
So you're
But a
by
raised
freckle,
freckle.
what do you mean?
Like a dark pigmented.
Pigment, okay, that's what it is. So it's a pigment. It looks like pigment on the nerve, right?
Yeah. So
pigment.
I would want to rule out melanoma first. But she has no other symptoms of melanocytoma. Some kind of met.
My lead one was another one. Anybody got one other one? For a pigmented lesion kind of around the nerve that I was wrong, but
Choroidal rupture.
I thought it might be a hematoma. You know, it looked to me more like you know, an RP, like a membrane, a pigmented membrane, sort of a hematoma. But anyway, that's what I thought.
They really like your differential.
So the differential is for a pigmented lesion on the optic nerve. So this is from a review paper by Dr. Shields. So exactly as you had mentioned, David, we need to rule out melanoma, could be an atypical nevus. Other interesting ones, and I put, I'm actually sorry, this one should have the photos I included.
Nobody gets cheers like that. You guys, like, what are we doing wrong? You know, they're having so much fun.
Cheers is for because there's someone dressed as a dragon outside, and there's this castle on this door.
Oh yeah.
And so everyone's like cheering them on as they like fight like a princess.
Oh.
They're outside. Someone walked in our room.
Wow, they get crazy for nurses.
Yeah.
Yeah.
I got bagels. For Dr. Three.
So sure, this one didn't include the photos I added, but so other things that could be a hyperplasia of the RPE.
Oh, wait, let me change it. I could pull the one up from your thing. Do you want me to change that? You know, I did. I have yours. The one you just sent, because you sent me one. Was the one you sent me different from the one on the thumb
Just
drive?
a few photos.
Let me pull that up.
For this differential, just in some of these I hadn't seen before.
Let me go to your thumb drive. which is still in there. We're still sharing, right? This is here, right?
Yeah, I should know it. Okay, so the top photo hyperpixel of the RPE, so we typically see like a chirpy in general. This one could be from trauma or ocular inflammation. The combined hamartoma, I think Dr. Cohen's already discussed,
No, just
or just a,
I thought that might be
a,
it.
a simple hamartoma. And then this one could have been with the retina and RPE. That's a photo in that middle picture there. And then in terms of an adenoma, so this one, I feel like if I just saw this on clinical exam, I probably would have thought it was nevus, a choroidal nevus. But this one would have more of a increased elevation, and then it wouldn't have that choroidal kind of base. It would be from the RPE.
And the thing about a choroidal nevus on the nerve, which Reed, you probably would, I didn't think you could get a nevus on because there's no choroid there.
Yeah, I haven't seen this before.
Yeah, I didn't think you could get a choroidal nevus on the nerve. So I didn't think of that as a differential.
Yeah, hamartoma would have been mine too.
Yeah, that was my choice.
But it's not, it more typically is fuzzier.
And it's more macular. It's not so much a nerve thing. It's more.
No,
You seen them on the nerve too?
Yeah,
Okay.
yeah.
Yeah, so go ahead.
And so there was a small consult with Dr. Shields, and she thought it was an atypical melanocytoma. She actually still gave it a good job. And then findings not necessarily consistent with an astrocytic hamartoma. She didn't have an overall MRI. It was normal. So then just routine kind of follow-up recommended after. So for melanocytoma, so it's a benign pigmented neoplasm. It's a variant of a nevus that affects the optic nerve, and it can also affect the retina, the choroid. In terms of demographics, the mean age of diagnosis is 50, slightly more prevalent women, I think it was like 63%, and then no race predilection, which does differ from melanoma, which would be less common in, for example, Asian populations, African American populations, but otherwise same kind of general age presentation. It's usually unilateral, can be bilateral in children, usually asymptomatic. Our patient had like all sorts of symptoms, but then no symptoms. It can interestingly have an RAPD, and I think the paper said there were, I think like up to 30% can have an RAPD. Just from the axons of the optic nerve getting compressed, even if they have normal vision. And they can have visual field defects, enlarged blind spot, they can have nasal steps, arcuate defects, also thought to be from compression of the optic nerve axons. So here are just some different photos. So top left is a fundus photo. It shows that hyperpigmented lesion. This one is more like classic in that it's that dark pigmented lesion. And the one for this patient was very muddled and gray.
So one of the things about these lesions that I have never seen in melanoma, unless they've mushroomed, is this lesion grows around the retinal vessels and obscures them.
Oh.
You just don't see that in melanomas. At least I haven't.
It's kind of invasive. It kind of goes through.
Yeah, it's not mushroomed. It's
right.
Yeah. So yeah.
And so B is the OCT that looks very similar to the one for this patient. It's that huge nodular elevation, and then the yellow points to those little hyperreflective lesions, and then the green can show some cystic spaces if there is some intraretinal fluid, or can even have some subretinal fluid or even heme, and then that that hyporeflectivity, that posterior shadowing. The fundus, the autofluorescence, it shows a strictly hypo autofluorescent lesion. You shouldn't have any hyper. And then lastly, FA ICG would show hypofluorescence. But if there's like optic dystrophy, it could be hyper. And ultrasound dome shaped and low internal reflectivity. But usually the thickness would not be, from what I read, as great as melanoma. Okay, so in terms of management, it would just be monitoring. You wouldn't have to do anything, but in the past, this was like far past, it used to be thought to be a melanoma, so those eyes would actually get enucleated. But now we don't do anything, just routine monitoring. And then in terms of prognosis and complications, usually they're stable. Some can enlarge. And then complications do include dyschedema, you can have fluid, you can also have exudation, hemorrhage. You can also have a CRVO or BRVO. And then you can have vitreous seeding, which from what I read, it was mainly if there was necrosis, and then those areas seed into the vitreous, and then you can rarely have transformation to melanoma, 1 to 2%. And then that's it.
That's good. Very nice. This was have you seen many of these?
Not like that.
But how many, I mean, it's my
Not-
first one I've ever seen. I've never
not-
seen one.
not-
As much as I've seen them in book.
Yeah, not a lot, some.
Yeah, okay. But not like zero.
So clinically, what are some ways of differentiating melanocytomas and melanomas?
I think what Reed said is interesting about them wrapping around the vessels and,
The mushroom.
and also just on the nerve. You don't get a lot of melanomas. I mean, there's no real melanin there. That's why if it's on the nerve, it's usually melanocytoma. This one was kind of light. I mean, this one was a little, and I think the autofluorescence, I did not get an autofluorescence. The melanomas will usually if they're real melanomas, usually get some autofluorescence over.
If you've gotten an FA, and you see these capillaries.
Oh, you can see in the melanomas. or
And
melanocytomas.
no, in the hamartomas.
Okay, I see capillary.
That's, and they leak, but, you know,
Thank you.
you didn't have leakage on the OC3, so.
Yeah, good job.
The FAs are nice, you know.
I know, I should,
I'm old
especially for
school,
conference.
Old school, I mean, you know.
All right,